So people keep reminding me of my previous trips to Chennai, and I've actually lost count now of how many times I've been here. It's a pleasure to be back. I've been asked to talk about current developments in insulin therapy. The timing for my talk has varied between, you'll see on the program, 30 minutes, 20 minutes, 25 minutes, and it is very short for a topic of this kind. So apologies first to those of you interested in feedback control of pumped insulin delivery. Apologies to those who are interested in regenerative medicine, islet transplants, and how that can develop and form insulin delivery in the future. Apologies to those of you interested in biosimilar insulins. I lecture for 40 minutes on that topic quite often. Also, there are the topics of premixes and co-formulations. They're being talked about later, as are some of the issues around combination therapy, in particular with GLP-1. So this is an overview, ladies and gentlemen, and I'll not be able to cover anything in particular depth, as you will see. I do advise all, and I mean all, the major insulin manufacturers on the development of new insulins, so I certainly have dualities of interest. These slides I've put together myself. They've not been reviewed by the sponsorship for the symposium. If we look back on the eras in the history of therapeutic insulin, they go back, of course, now about 100 years when Georg Zolzer was first isolating insulin, something which was stopped when he went to the front to fight in the First World War. And then all the other developments we've seen over time. But what's really of interest with the current developments was the advent in the late 1970s and commercially in the early 1980s of genetically engineered insulin, initially viewed as a way of getting human insulin into human beings. But then, because of the foresight of the chemists at the insulin manufacturers, the designer insulins, the idea that with genetic engineering you didn't just have to produce human insulin, but you could produce novel insulin analogues with novel properties for novel purposes. And I'm going to talk about insulin analogues and derivatives then of human insulin in some further detail. It's interesting to note that insulin has been associated with no less than 6 Nobel Prizes. You'll recognize the 2 characters at the top there. Perhaps the most scientific of all, though, was Sanger and his chemistry Nobel Prizes. The first one for the 2-dimensional amino acid structure of insulin. It took him 6 years to actually do that work. You may recognize Dorothy Hodgkin, whose team worked on the 3-dimensional structure, and Roggiello and Will Gilbert on the right at the bottom, who worked on the genetic engineering. This slide has a point, really, that insulin is a complex protein, though not a very big one. Because it's a complex protein, it's resisted attempts to actually imitate it with, say, small chemical molecules which bind to the insulin receptor, which otherwise might seem obvious to you and me. And despite the huge clinical need, despite considerable scientific input, we're still giving it essentially the same way as we were in 1922 and 1923, despite very much increased understanding of receptor interactions and cellular pathways of action. So it's still certainly a struggle. What are we attempting to do? Well, Antonio Chiaro just referred to the issue of glycemic excursions. This here in blue is the glucose excursion you see in normal people given a big English-type breakfast in Newcastle. And far from going up to 8 or 9 millimoles per litre, you'll see the average peak is below 7 millimoles per litre, below 126. And in fact, you're only above 5.5 or 100 milligrams per deciliter for 30 minutes. So nature hates glucose excursions. And to do that, it achieves something remarkable. It pushes insulin concentrations up to a peak in 30 minutes, filling a whole 15 liters of glucose space with insulin in 30 minutes, and then regulates the decline back to basal levels in 4 hours. So this is the physiological profile we're trying to imitate with our mealtime insulins. Note also, contrary to what you might think, that basal insulin delivery in normoglycemic, non-diabetic people is absolutely flat. That's insulin and C-peptide has the same flat profile, so this is not a clearance problem. So what we're trying to imitate with basal insulins when we get back to normoglycemia is flat insulin delivery during the night. So physiologically, basal insulin delivery at night is very flat in contrast to the extended acting insulin preparations, and mealtime insulin delivery gets to that peak in 30 minutes, 45 minutes, and back to baseline in 4 hours. But of course, this is not the whole story. Even if I could get physiological glucose levels like this, physiological profiles, I wouldn't get normoglycemia. And that's because I vary my insulin secretion as somebody who doesn't have diabetes according to my meal size, according to my insulin sensitivity, my exercise yesterday, how much I slept last night. So we still can't get back to closing the loop at present without other ways of monitoring glucose. So this is the, as it were, pseudo three-dimensional structure of insulin. And of course, the genetic engineers realized that by tampering with the end of the B chain, they could actually produce insulins which are monomeric after injection, even though hexameric and therefore chemically stable in the vial. And there we have the substitutions which give us the rapid-acting insulin analogues, insulin Lispro, insulin Aspart, followed later by others. Because they're out here on this terminus, the B chain, they don't interfere with receptor interactions, and therefore this acts in the same way at the receptor as human insulin. When we looked at the proof of concept in a phase 2 study, back now some 15 years ago, you can see here's the glucose profile for human insulin with note a excursion in type 1 diabetes really to quite unacceptable levels, double normal peak postprandial levels after breakfast, halved with the rapid analog. And the reason you can't get perfect control here is simply that you'll see you're already hypoglycemic. Thanks. You're already hypoglycemic at the end of the night. So an additional problem here is that you're asking your mealtime analog to correct the defect here of MPH. Note that later on in the day, in fact, the analogues, and we showed this for Lispro as well, do much better. And that's true even after dinner, and it gives you advantages also during the night. Now, as well as the short-acting insulins, then we have designer prolongation of action. And I highlight here 4 approaches which actually look like 3, but are 4. They are different. The first one, of course, we saw commercially was the idea of changing the PK of the insulin so that it's soluble in the vial, but precipitates to form microaggregates after injection, the principle of insulin glargine, and we'll look at that again a bit later. Then with insulin detamere, adding a fatty acid moiety led to albumin binding, particularly in the tissues after injection. And that led, of course, to delay in absorption because the albumin-bound insulin could not diffuse as fast into the circulation. That mechanism actually was an accident. What the chemists were trying to do was actually form multi-hexamers with the fatty acids. And they went on to do that with insulin degludec. We'll look at that as well. Then later on, we've also seen the idea of attaching insulin to a large molecular weight complex, PEG, giving you a large molecular weight moiety, which then can be absorbed more slowly. And that's relevant to some other developments I'm not going to be talking about, because we're now looking at once-weekly insulins, where we actually attach the insulin to IgG and IgG derivatives, and therefore slow down its absorption that way, the same way as is done, of course, for some antibodies used in other non-diabetes products. The advantage of acetylation relates somewhat to the previous talk. This is the within-person 2 standard deviations of pre-breakfast blood glucose level with an acetylated insulin detamere, compared to the NPH. And what you'll see there is that you get a reduction in the day-to-day variability of the glucose levels pre-breakfast, which is the best test of a basal insulin, due to the acetylation. And that occurs, of course, because the acetylation leads to fatty acid binding of the insulin in the circulation, produces you a huge pool of insulin in the circulation, which is bound, not free, and that acts as a buffer when insulin absorption from subcutaneous tissue closes. So this mechanism, as well as extending the action of the insulin as insulin detamere, also reduces the variability of the effect of the insulin. And that's positive, because that's part of the problem that gives you the hypoglycemia and therefore leads us to back off on insulin dosage. You can see that a little bit here as to what is actually achieved when you combine one of the new analogues with the mealtime insulin analog. In this case, this is combination of aspart and detamere, and you can see the aspart taking away the mealtime peaks and the analog actually reducing the pre-breakfast blood glucose levels. And it's really the combination of these 2 products that is successful. I should say, in fairness, we did a similar experiment, Ashwell et al., with insulin glargine and insulin lispro. Again, you get the same effect. You get improvement of HbA1c and still a reduction in nocturnal hypoglycemia. So the combined analog approach is definitely the way forward in type 1 diabetes. We now come to newer mechanisms, and this is insulin degludec. As I've said, it's acetylated, and here the fatty acids are indicated by the black lines. And the idea then was that the insulins would be able to combine by the fatty acids, but within the vial, that's actually limited to a dihexamer, and that's limited by these phenols which bind at the ends. Phenol, of course, is a charged organic substance, repels the molecules, so you just get the dihexamers. Phenol, of course, is a normal part of insulin preparations and has been for close on 80 years now, so that's not new. You'll notice also the zinc sitting in the middle, which actually allows the hexamer to form in the first place. Now, when you put this, inject it into the subcutaneous tissue, the effect is that the phenols diffuse away quite quickly, in fact. And the result of that is that it combined to form these long chains, which you'll realize now when they dissociate for their ends here, actually will give you a constant delivery of insulin over a long period of time. These are the clamp studies demonstrating that. The degludec in dark blue is at the top compared to glargine. This is actually looking at pharmacokinetics, so serum concentrations of insulin. And you can see the much longer, on a log scale, the much longer persistence of the degludec as it's absorbed from the tissues. In fact, the half-life of insulin glargine is around 12.5 hours, that of insulin degludec about double that at 25 hours. And that really means that this is an insulin which is going to be fairly stable for 36 hours or more. Now, whoever drew this slide didn't understand diabetes, and what actually matters here, since we give these things daily, is the trough ratio, or rather the peak to trough ratio. And you can see the peaks here are about the same. The troughs are different, however. So degludec has a lower peak to trough ratio, which means you can give more insulin and get less hypoglycemia than glargine. At least that would be the theory deriving from this graph. So what happens in practice? Well, in practice we have a problem with insulin studies, and that is we do treat-to-target studies. And if you do treat-to-target studies where the target is glucose, believe it or not, you get the same glucose levels. And that's been shown in type 2 diabetes, of course, starting with the famous treat-to-target study, but also in virtually all the studies we've done of new insulin since. So not surprisingly then, if we look at insulin degludec compared to insulin glargine, here in people with type 1 diabetes in clinical practice, you end up with the same HbA1c as expected, and the treatment difference, in fact, was non-inferior. Where you see the difference, if you do that, is in hypoglycemia. And here's the glargine data compared to degludec again, both given once daily, combined with mealtime insulin, and this again in type 1 diabetes. And you will see here we're talking about approximately a 25% risk reduction. Remember, these people are still using the same mealtime insulin, so their mealtime contributor to hypoglycemia is unchanged. So here in type 1 diabetes, the data perhaps a little bit less convincing. In type 2 diabetes, but consistent on meta-analysis, is a difference in hypoglycemia. Now, in clinical practice, you and I treat to hypoglycemia because our patients tell us they don't like it, because we don't like low blood glucose levels. We actually equalize the hypoglycemia, and I would expect in time, if you did a treat to hypoglycemia level, you would see a separation in HbA1c. But as yet, no one with any of the new products we have has done a successful treat to hypoglycemia study. Sanofi's response to that was to look for new ways of extending the action of insulin glargine. The 100 unit per mil glargine I'll have to refer to by its proprietary name, of course, of Lantus. So essentially what this means is simply putting the same number of units in a smaller concentration of injection liquid, giving a smaller injection depot, and therefore getting a more compact precipitate in the tissue. More compact precipitate will then dissociate and dissolve more slowly and be expected to give a longer, more prolonged time of action. And you can see that this in type 1 diabetes here, where the Lantus is, sorry, these have got reversed in color, haven't they? The Lantus here actually appearing in green with a higher peak to trough ratio than the U1300, both of them being somewhere down below effective levels by 24 hours. So you get a glucose infusion rate then with the correct color here, which is more consistent and more persistent to 24 hours with the U300 compared to the U100 preparation. As a result of that, you also see a later escape of glucose levels. But this is something of an artifact because these people are more less starved at 24 hours, and therefore the glucose levels tending to go down anyway. So proof of concepts, again from the clamp studies, and with lower peak to trough ratios for the new insulin, you would expect less hypoglycemia. Here again, the HbA1c, the primary endpoint was at month 6, and you can see here HbA1c again, not different. It was very slightly clinically different in favor of the new insulin by 1 year, but essentially very similar. And you can see the same effects occurring for fasting glucose, although here the advantage is not statistically significant. This was in fact done in type 2 diabetes in this case, and the data here also from the published studies is in type 2 diabetes. These are also in people who are obese with an average BMI of 33. And you can see the reduction in the two studies, one being on a multiple injection regimen, the other being on basal insulin alone. You can see a reduction of 20% or 30% in nocturnal hypoglycemia with the new insulin compared to the conventional U100 Lantus. So again, we're seeing improvements in nocturnal hypoglycemia, and again, we need more experience and in other studies to take this forward. Presently, the data for this new preparation in type 1 diabetes is very similar for both hypoglycemia and for HbA1c. Then another approach would be the pegylated insulin. Currently, there is no product in continuing development, Eli Lilly having announced they've actually suspended, they say, for 12 months the development of the insulin. And I think probably, although they did not announce what it was, the reason is on this slide at the bottom here, where you'll see the ALT in this study was quite markedly higher with the new pegylated insulin than it was with insulin glargine. Now, the characteristic of a large pegylated insulin like this is it's hepatopreferential, and they've convincingly showed that. So what we're seeing here, in fact, is that insulin is now being targeted to the liver, and that, of course, is activating fatty acid synthase so that you're getting more fatty liver. And this, as I discussed yesterday, is why hepatospecific insulins and hepatopreferential insulins are not likely to be desirable in human beings. Note this pans through, we're getting lower HDL, and we're getting higher triglycerides as well with insulin. You'll also get other effects. I'm not going to discuss the body weight issue here, but you'd expect with a hepatoselective insulin to get hypoglycemia, which is worse during the day, because, of course, you're suppressing hepatic glucose output, so the person can't counter-regulate as adequately, although it will be better during the night because of less excess stimulation of glucose disposal peripherally. And anyway, this insulin has a longer and flatter profile. And that's exactly what you find with the data. Anytime events are increased, despite the fact that nocturnal events are decreased, data from those two studies. So this particular mechanism is not likely to go further, but perhaps other pegylated insulins, which are less hepatopreferential, might go further. Then I'm going to finish by talking a little bit about other approaches. It says basal and rapid. This is actually rapid-acting insulins, new mealtime insulins. And those of you who've watched the posters at meetings like the ADA and ESD will have seen quite a number of approaches towards this, including such things as finding means of avoiding phenol, which means, of course, you've got problems of stability and bacterial control. Removal and chelation of zinc, again, because that binds the insulin into the hexamers. I'm going to talk a little bit about faster-acting aspart, which uses nicotinamide, though the chemists at Novo tell me they don't know and are not sure what this is doing. Biochaperone insulin, I'm not clear what that is even. Hyaluronidase dissolves the tissue around the insulin, certainly leaves you with much more rapid absorption, but I find it difficult to see that a commercial product can come out of combining recombinant hyaluronidase at some expense with insulin. And then, of course, there's the Afrezza respiratory tract inhaled insulin, which is now on the market in the US, and again is a topic I can't address in detail today in remaining time. But let's look at the approach of the faster-acting insulin aspart with the nicotinamide and removal of some of the other excipients in the vial which tend to produce binding. And when looked at in mealtime test responses, these are blood glucose levels. This is type 1 diabetes, presented last summer at the ADA. Here's insulin aspart in the black. Again, you see rather bigger excursions than you would like to have, of course. Remember, I told you that you only go up by about 2 millimoles per litre in physiologically. Here it's going up 6. But notice that the faster-acting aspart cuts the peak off here. Perhaps we would have liked to see a bigger decline in the rate of rise. But proof of principle anyway, and you can see reductions of blood glucose response endpoints there of the order of 1/4 in the first 2 hours and the order of 1/3 overall. Now, what we want to see is the results from the clinical studies with this insulin, and sadly I can't show you that data already, but only 2 weeks ago now, Novo Nordisk did release a press release, which I picked up on the wire, and this was the headline results from the 3A trials for this insulin. And I've just put quotes here because I can't interpret them any further. The HbA1c lowering achieved with faster-acting insulin aspart was significantly larger than that achieved with Nova Rapid, and it was associated with less increase of postprandial glucose during the meal tests. So it looks as though that they may be getting some positive results. I would not expect this improvement in HbA1c to be very large, but perhaps combined with the newer long-acting insulin analogues like insulin degludec, just as we did with lispro and glargine or detamir and aspart, we will get clinically useful reductions. We also, of course, need to look at the hypoglycemia data, and all I'm going to do today is smile at you and say you'll have to wait till later on this year. Lastly, then, there are other issues, and I alluded to those at the beginning. We still only, with the best possible therapies here, are getting further reductions of 25% in hypoglycemia, and that's because of the lack of feedback control of insulin delivery after we've injected it. And of course, in open-loop pumps, the same issue applies. So we're not really going to get rid of hypoglycemia in people with type 1 diabetes anyway by improving the insulin profile further. We know from press releases that sensor-controlled pumped we know from published studies that sensor-controlled pumped insulin is making progress. I remind you that that was first suggested in 1974. It was first published in Lancet in 1983. Progress has accelerated recently, but it's still problematic because the sensing is still subcutaneous and the delivery is still subcutaneous. And of course, I do it intravenously and can therefore respond in 8 to 10 minutes rather than in an hour or so. Smart insulins, we know that Merck have announced they've got a smart insulin which is sensitive to glucose concentrations in its action, and they're developing that. I predict it will be a long development process and difficult. And Novo Nordisk have said, again in investor communications, that they're looking at smart glucose-sensitive insulins as well. So maybe we'll see something there in 10 years' time. And that might also be the timescale for regenerative medicine as we try and take self cells from subcutaneous tissue, convert them to islet-like tissue, and get them to produce regulated insulin and then re-inject them. Regenerative medicine may be able to give us bioengineered islet beta cells, which will be effective within 10 years or so. But sadly, meanwhile, with all these things, we're going to be having to use our injected insulins to good effect, and that's going to depend as much on your brains and the brains of your patients as it is on the insulins themselves. I thank you very much for your attention.